Thank you for joining us today for our Migraine, Dizziness, and Vertigo presentation. My name is Gina Ora, and I am the Physician Liaison at McLaren Bay Region. During today's broadcast, as questions come up, please feel free to comment, and they will be addressed at the end of the presentation. Today, I have the honor of introducing Dr. Candice Colby, an ENT, which is an ear, nose, and throat specialist, and she is also the director of the Cochlear Implant Center with McLaren Midland ENT. Dr. Colby, welcome.
Thanks, Gina. Thanks for having me. It's really nice to be here to talk about this topic today. So I'm going to talk about migraine, dizziness, and vertigo and how they all play a role together. So my objectives today are to briefly discuss the balance system, just so there's a little bit of background, and describe how to talk about dizziness to your doctor so that it can help them determine what may be the best management options for you. To review migraine, its association with dizziness, and some treatment strategies. And then I'll just kind of briefly touch on a few different types of dizziness and how we manage those. So this is a picture of the inner ear and the balance system. It's the hearing organ with the cochlea, and then there are 3 balance canals that help your inner ears sense gravity and motion. And the slide on the right is really complicated, but only just to show you that it is the inner ears that sense gravity and motion, but then there are multiple pathways that it goes through to get to the brain. So if there's a disturbance in any one of those parts of the pathway, it can lead to dizziness. So when we talk about balance, it's essentially like a tripod. I think of it as input from 3 main systems: the balance or vestibular system, your eyes being able to see where you're going in space, and then proprioception or your sensation, being able to feel where you are, feel where your neck is, feel your upright posture. And again, to show that each one of these inputs then is coordinated in the brain and then leads to an output, either of your eyes or your spine or your muscles, to help keep you upright in space. So another an important reflex that we can measure where all of these things are integrated is called the vestibulo-ocular reflex. And that's where the eyes are held in place when you move your head despite head movements. So when I move my head, my eyes stay still. And so that's an important reflex that I mentioned because that's something that we can measure. And it's almost like a window into the inner ear to help us figure out what's going on to determine the type of dizziness. And when there's a problem in the inner ear is when nystagmus occurs. And this is a to and fro beating of the eyes. And this can be used to measure the balance system. Sorry, my slide's not working here, but it's to and fro beating of the eyes. And that can help us determine which ear may be involved and which balance canal may be involved. So when you see your doctor for dizziness, is something that they may be looking for. So when we talk about dizziness overall, dizziness is really an imprecise term. So I ask people to describe to me what they're experiencing without using the term dizzy. So some other ways to describe it are foggy-headed, swimmy-headed, true spinning vertigo, feeling like you're going to faint. And again, dizziness may or may not be coming from the ear. There's other causes throughout that pathway that could be contributing. So it may be neurologic disease, could be psychologic disease. Anxiety causes a lot of dizziness as well. Could be a heart issue. So when you describe the dizziness, it's helpful to be as specific as you can for your doctor to figure out what's going on. It's obviously very common. It's the 9th most common primary care visit complaint, and obviously gets higher and increases with age. So I want you to describe it without using the word dizzy. Is the room spinning like you're on a merry-go-round? Are you lightheaded or feeling like you're going to pass out? Are you just off balance and unsteady on your feet? Are you foggy or swimmy-headed? And one main thing that we look out for is that severe dizziness with true spinning vertigo can be a sign of a stroke. Oftentimes it's associated with other symptoms such as difficulty walking, weakness or drooping of the face, or numbness or weakness of the arms and legs, but not always. So if there's severe spinning with nausea and vomiting, a stroke should often be ruled out first. So getting into one main cause of dizziness that I see in my clinic is actually chronic migraine. So just an overview of migraine itself. We think of migraine in sort of the classic way as a one-sided or unilateral headache that's characterized by a prodrome, or a kind of a sense that something's going to happen, with a mild headache, some nausea, sometimes the visual disturbances that you hear about with the kind of funny vision changes. And then that leads to the severe headache, which is mainly secondary to pulsating vessels and dilation of those blood vessels in the intracranial cavity. And that is accompanied by nausea, vomiting, and then relief of the headache and postdrome. So that's the typical migraine that most people are aware of. When you think about migraine, it's very common. You probably have migraine or know someone that has migraine. Every 13 to 15 out of every 100 people have migraine. Obviously more common in females. Most common age range is about 30 to 50 years old. And there's a cumulative lifetime incidence of about 43%. So half of women experience migraine sometime of their life. It can be a lifelong problem. Typically, there's a lot of more pain in the younger years. And then as you get older, things change, hormones change, and there's less pain associated, but then you may have some atypical symptoms such as dizziness. It's one of the main causes of vertigo, particularly in my clinic. It's second most common to BPPV, or positional vertigo, which we'll talk about a little bit later as well. So there's multiple different theories as to why migraine occurs. Neurotransmitter changes, which are the chemicals that help with the transmission or pathways in the brain. And there can be chemicals in certain foods that we eat and other things that we'll talk about that can mimic those chemicals. And so that leads to hypersensitivity of the brain. It can be vascular or spasm of the blood vessels, like I mentioned, or even some alterations in metabolism causing some disturbance within the brain as well. During a migraine attack, all of the senses can be more heightened. So things that may not bother people that are not having a migraine, like sunlight or noises, or even kind of some balance issues, may be a lot more sensitive to people that are experiencing a migraine attack, because all of their senses are heightened during an episode. Migraine is often associated with dizziness, vertigo, and imbalance, and it's the most common cause of dizziness that presents to a specialist, a neurologist, or an ear specialist such as myself. And there's two different types, really, episodic or chronic. So episodic is what we typically think of, where there are different episodes in time of migraine where you're fine in between. But there's also a chronic migraine that can occur with episodes, and then chronic vestibular balance dysfunction in between the episodes that leave people feeling chronically dizzy, imbalance, fogginess, difficulty concentrating, and all different sorts of symptoms like that that can occur between the severe episodes. Vestibular migraine is also a more specific diagnosis given to migraine that occurs frequently with dizziness or attacks in the inner ear. It often occurs with other causes, so it can be a little bit confusing when you present to your doctor. It occurs frequently with positional vertigo, or BPPV. There's also something called pseudo BPPV, which can be confusing. About 50% of patients with migraine have motion sickness, so oftentimes they complain that they weren't able to go on long car rides as a child, or ride on roller coasters, and sometimes even with syncope or feeling as if you're going to faint. Again, the dizziness can be really nondescript. It can be any type of fogginess, lightheadedness. It can give you true vertigo as well, and sometimes has tinnitus or hearing loss. Tinnitus is head noise that you hear that no one else hears. Very common in the population, mostly from hearing loss, but can be secondary to migraine as well. Oftentimes the symptoms are worse with motion, and typically improve when lying down or resting. So there's no diagnostic test for migraine, unfortunately. It's really a diagnosis of exclusion. There are a few criteria that are mainly involve multiple attacks, history of a traditional migraine headache, moderate to severe symptoms that last 5 minutes to 72 hours, greater than 50% of episodes associated with one additional feature, such as photophobia, which is difficulty with lights or difficulty with sound, or an aura, something like that. And again, it has to be being able to attribute to another disorder. Things that can trigger migraine, a big one is diet. So again, there are different things in our diet that we'll review that can cause the brain to be a little hypersensitive. It can mimic the chemicals that are in our brain, causing it to trigger a migraine. That's the one that we really can control. So I like to stress that, which is why it's in bold. Environment. So other, people have some sensitivity sometimes to fluorescent lighting or computer screens when they're at home on their computer all day. Certainly weather changes, barometric pressure changes. So when the clouds roll in and the low pressure systems come, that's when people usually say that they can develop migraine. Hormonal changes, stress, anxiety, and a number of different triggers that are listed as well. So there are some chemicals that are similar to our natural neurotransmitters that are found in food. And sometimes people come in and they say, I've been drinking the same cup of coffee every day for 40 years. It can't be that. Well, sometimes, unfortunately, it can. So I have patients stop all caffeine. That's really the biggest trigger, and actually improves people with migraine about a third of the time. And it's also in other healthy foods. So people may also come in and say, well, I eat really healthy. I don't eat any preservatives. It can't be my diet. But again, it's not just unhealthy foods, but actually some healthy foods that contain some of these natural chemical compounds. So chocolate, we know, red wine, and those things, but also some other amino acid producers like milk and dairy products, avocados, bananas, nuts, and also obviously cured foods, broccoli, walnuts. So the list is extensive, but it's not all things for all people. So you really just have to find what your triggers are. And we work with people to do that, obviously. And some fermented products like red wine, beer, aged cheese, some alcohols, nuts, I mentioned. I don't tell people that they can't drink any alcohol, but you really have to stay away from the fermented products like beer and wine. And clear liquors like vodka tend to be less of an irritant or a trigger for people. I don't want to take away all your fun. So again, the list can be extensive, but we really work with people to kind of find what their triggers may be. So the mainstay of treatment is really trigger avoidance and identification of these triggers. And so we initially try to eliminate as much as we can, and then can slowly add those foods back in. Again, the main one is caffeine, and really stressing a regular sleep cycle and exercise. Actually sleeping in on the weekends or altering your sleep patterns it can be really detrimental to this progress as well. And so keeping a regular cycle and schedule is what's most beneficial, at least during the beginning kind of identification and treatment process. And then if that doesn't work and we need to add additional things, we can do abortive medications for an attack that you take when an attack comes on, and also supplements that you take every day, particularly magnesium and vitamin B2, which are really helpful in preventing the attacks from coming on. If the symptoms are persistent despite all of this, or if someone presents with chronic symptoms that have been debilitating for months, that's when we do a daily prophylactic medication. The mechanism is not well understood, but they work actually 75% of the time. It can take weeks to months for a full effect. And having a response to the medication actually can help us establish a diagnosis as well. And so these medications are in multiple different categories, including those that alter serotonin, like antidepressant medications, those that work on blood vessels, like blood pressure medications. And so we just have to do a little bit of trial and error in finding the medication that works the best for you. I also explain to people that this does not have to be a lifelong treatment. And so often we do a medication for a 3 to 6 month period to get some improvement. And that way it helps us to actually identify the triggers and do more elimination going forward. So it doesn't have to be forever, but sometimes just a short period of time for a brain reset. In addition, I want to just mention physical therapy. Oftentimes physical therapy is recommended for these patients who present dizzy. But physical therapy can be a little bit more, it can be more troubling in the beginning because you're already feeling kind of crummy. And so doing more head movements and motion until we get the symptoms under control can actually not be helpful. So what I recommend is that we get things under control and get some improvement, and then consider physical therapy to help with the brain integration and helping the balance from there. There's some great books out there. This Heal Your Headache book, the 1-2-3 program, is essentially like the Bible for us. I recommend that to all of our patients. It explains a lot of the history, and I think it helps validate a lot of people's symptoms and a lot of things that they've been experiencing that they didn't really know what it was from. And there's great diet books, the Migraine Relief Diet, and there's a lot of guidance out there once we figure out exactly what's going on. There's a couple of other migraine variants that I just mentioned because migraine can be so vast and have so many different causes and so many different types. A couple are, one additional is basilar migraine. So that is really severe vertigo with additional severe symptoms, visual symptoms. That can have numbness or weakness and can be very similar to stroke-like symptoms. So a stroke certainly has to be ruled out. But if that's all negative with similar symptoms, then basilar migraine should be considered. There's also something called benign paroxysmal vertigo of childhood, and that's essentially migraine of childhood. So we used to think that it was BPPV or this positional vertigo because kids often have positional symptoms. It occurs sometimes between the ages of 1 and 4, can be associated with vomiting, disequilibrium, not usually hearing loss or tinnitus, and certainly more serious conditions should be ruled out first. So it is a diagnosis of exclusion. We don't really know why this happens, and the thought is even some children with colic may be secondary to migraine as well. So I think we're learning more and more as time goes on. All right, moving on to BPPV. I've mentioned this a few times. So this is also a very common complaint, a very common cause of dizziness. And again, just to give a little bit of an overview as to what we're talking about, you may have heard of the crystals loose in the inner ear. I'm sure you or someone you know has experienced this too, or you may have heard about it. So in those valence canals that I mentioned, there are layers of calcium carbonate crystals that sit in a gelatinous layer, and they help sense gravity and motion. When we move our head or turn our head, it helps sense that gravity. And so sometimes those crystals, for whatever reason, can break loose and become free floating in the valence canals. So when you turn your head and the fluid inside the canals stops moving as it should, the crystals keep moving, and so it makes you feel as if you're still in motion or spinning. And so we need to do maneuvers to get those crystals back into place. Again, it's very common. So it's about 1.6% of the population that has BPPV every year. And it's about 20% of all dizziness seen in medical offices, and certainly, common in my practice. It becomes more common as you age. And so 50% of all dizziness in older people is due to BPPV. And we usually try to explain to people about 60% of 60-year-olds have had BPPV and 80% of 80-year-olds. So most of us experience this sometime in our lifetime. And it's usually brief positional vertigo. So meaning when I roll over in bed and turn my head to the left, I have vertigo for 30 seconds. It may be associated with nausea, vomiting, and it also can lead to a sense of imbalance, lightheadedness, kind of fogginess when you're up, around, and moving about as well. And even when the vertigo gets better, that often lingers for a little while. So I tell people to expect that for at least a couple of weeks. Another typical complaint is when women are getting their hair shampooed in the bowl, or certain yoga or Pilates positions as well. Some risk factors are head trauma, age, or other disorders of the inner ear just due to degeneration of the inner ear and the hearing. So this may be present for a few weeks, stop, come back. It can recur. So each time it recurs, we really just have to treat it when it comes on. It does occur more often in the winter than the summer. So the thought is perhaps low vitamin D may play a role. So when it does recur, I tell people to really check their vitamin D levels or take vitamin D supplements as well. So it's diagnosed really based on history and physical exam. So the history, pretty classic of what I mentioned. And then also we do that test looking for the nystagmus, or those funny eye movements. So we lay a patient back and take a look at their eyes and see if we can get a sense into what's going on in the inner ear. The office maneuver to treat BPPV is very effective. So if done correctly, it's effective in nearly 95% of patients. Sometimes if you have mobility issues or fear, or if you're really having trouble getting it treated, physical therapy can be very helpful in adding to the treatment with this. And so what I recommend is the Epley maneuver. It can be Googled. You can look at YouTube videos, and I tell people to do it 3 times a day for 3 days. And then again, you might have those lingering kind of imbalance symptoms for a couple of weeks, but if it's not better after that, then we need to look into it further. And the epli I have kind of outlined there, really is just turning your head to one side, laying back, turning to the other side, rolling over, and then sitting up. And then you sit upright for 30 minutes, and that allows those crystals to fall back into place and hopefully stick into that gelatinous material. It can recur, like I mentioned. So about a third of patients have a recurrence in the first year, and about a half have a recurrence by 5 years. And again, it's miserable, but we do just have to treat it when it comes on. If it recurs and persists, sometimes we treat for migraine, which can be a risk factor for recurrent BPPV. And also there is a surgical procedure called posterior canal plugging, where we essentially plug off the balance canal, but that's really reserved for patients who have had long-term symptoms because it can be associated with hearing loss from the surgery. A couple additional common causes of dizziness that I see as well. Another severe cause is called vestibular neuritis or labyrinthitis, which is essentially inflammation of the balance nerve or the inner ear hearing structures. And this is severe constant vertigo associated with nausea, vomiting that typically lasts for about 3 days, followed by imbalance. So this is essentially loss of balance function on one ear. And so it's more severe than the vertigo associated with BPPV, more severe than the vertigo with migraine, but sometimes it takes a little while to tease that out. But again, it's vertigo lasting for days, no matter your head position or no matter what you do to try and stop it. So it can be pretty miserable. It may or may not have hearing loss associated with it. Obviously, because of the severe dizziness, stroke should be ruled out, and you should be evaluated by an ear, nose, and throat doctor to rule out or evaluate for hearing loss. It's sometimes difficult to tell when you're feeling so bad. Steroids, if given in the early stages, can help lessen the duration and severity of symptoms. And if a patient has a sudden hearing loss, then we really want to get steroid treatment soon. So if there's inflammation in the inner ear that causes a sudden hearing loss, we can sometimes rescue or treat that hearing loss with steroids and get it to come back up to normal. It's best if we do that within the first 2 weeks and certainly within the first month. So that's why it's really critical to get your hearing tested very quickly once that happens. So sometimes I see where people will be told that maybe they have fluid in the ears, maybe try a round of antibiotics, but I think that can be a disservice sometimes, because we really need to test the hearing and make sure it's not a nerve damage hearing loss rather than a fluid hearing loss, because that gives us the opportunity to bring the hearing back with steroids. Whereas if we wait to see if fluid clears up or something and it ends up being greater than a month, then the chances of it returning are worse. Okay, moving on to more of a general imbalance. So again, balance requires input from 3 main systems, the ears, sensing gravity, your eyes, seeing where you're going, and sensation, or feeling where you are in space. So your feet touching the floor, your spine, feeling if you're upright, and your head on your shoulders. And so it also requires additional things such as your cerebellum or your brain to kind of coordinate those 3 inputs, and also muscle strength, joint strength, everything that is needed to stand upright and walk. So if there's a problem in any of those other areas, it would be considered a non-vestibular cause of imbalance. And so some big causes are aging, which is also called presbystasis. If you have an orthopedic injury or perhaps a knee replacement or a hip replacement, that can give us different sensation or faulty information from those sensors that live in that area. So your brain's not getting the information that it once was. And so that can leave you with some imbalance in the system. Neuropathy, or having trouble with sensation or feeling where your feet are touching the ground, such as in diabetics. Vision problems obviously would cause an issue as well. And then talking about presbystasis, just as we age, there are lots of different factors that play a role in why we lose balance function with time. And that's loss of muscle bulk, loss of joint range of motion, increased time for us to react. And then decrease in activity level just decreases your overall mobility. And for some people, they have a significant anxiety or fear of falling, which can lead to overcompensation, which is actually more detrimental and can lead to more balance problems and falls. So the treatment for all of these issues is really physical therapy. So physical therapy is great in that it helps retrain the brain to know what these inputs are that you're feeling. Say, for instance, if you had a knee replacement or a hip replacement, you really need to retrain the brain as to how to use those new joints and to what information it's receiving is normal or shouldn't react to it, and how to get then the other side to compensate for maybe where you're lacking on the other side. And again, for strength, balance, and just really endurance training, and also for safety. So physical therapists are great to help with safety at home and also to teach you how to protect yourself and maybe some activities that you can do to prevent imbalance and falls. So I think it's important as we age to keep moving and to keep those things all in mind. Another factor, which can be a big factor with our elderly population, is polypharmacy. So polypharmacy is essentially multiple medications. So it's generally considered more than 4 medications that you take daily. And when we look at the population, looking at these numbers, we're talking about people age 60 and older. I wouldn't really call that elderly, but that's how they defined it, unfortunately. But this population is growing because we're getting healthier, we're living longer. And so that's expected to be 1 out of 5 people by 2050. So again, with the balance and with polypharmacy, this is something that we're going to have to figure out how to deal with. On average, 2 to 9 medications per day are taken by the elderly population. And so, and then the prevalence of inappropriate medication use throughout the world can be pretty high as well. So I think it's just important. It doesn't mean that you should stop any of the medications you're taking. However, there are times when perhaps having a conversation with your doctor may be useful. And what I mean by that is that there are some side effects of medications. Beta blockers, for instance, are one where it's not necessarily a side effect, but it's an effect that's supposed to occur with the medication. So the medication is supposed to keep your heart rate at a lower level so that it doesn't jump up and it protects your heart. Well, if you need to stand up quickly, you need your heart rate to elevate to pump the blood up to your head so you don't get lightheaded. But that medication prevents that from happening. And so while it's a side effect of the medication, it's a necessary side effect because that's what the medication is supposed to be doing to protect your heart. But talking to your doctor about maybe some other ways that you can become hydrated to prevent the dizziness from occurring, or if there's an alternative medication that can be considered if you're having side effects from that one. In addition, there's also medications that can interact together. And so maybe a combination of a couple of medicines are not the best option for you as well. So just something to think about when we're thinking about adding more and more medications to our prescription list. Lightheadedness is essentially that feeling like before you're going to faint. So just feeling a little bit out of it, or feeling like you have to stop moving or stop doing what you're doing so that you don't pass out. It can be caused by low blood pressure, like I mentioned with the beta blockers, or medication side effects. There's also something called POTS syndrome, which can be contributing as well. Sometimes it has additional symptoms like chest pain, trouble holding urine, et cetera. So those are things that you want to be sure to mention to your doctor if they're occurring. It's very common, and it's actually more frequent due to medication side effects than it is to an inner ear problem. We treat this again with hydration, volume expansion, sometimes with salt or fluid increases, and exercise can be really helpful to teach your blood vessels and train your brain so that you don't become lightheaded with certain activities. So in conclusion, dizziness is an imprecise term that can include many different causes, and it's helpful to really break it down and have a conversation with your doctor about what that really means, and find some more specific terms to use when it comes on, how long it lasts, additional signs and symptoms that you may be experiencing with it as well. Migraine is a very common cause of dizziness that's previously been unknown or maybe not commonly known. And that and BPPV are the most common causes of dizziness. Migraine is managed mostly with avoidance of triggers or identifying those triggers, and diet with medication as necessary. The one thing I forgot to mention is that we focus a lot on diet because it is the one thing that we can change. Our threshold may be changed from the weather or our stress level, or maybe we didn't sleep so well at night. And those things are a lot harder to control. So on those bad days is when diet really may be playing a role. Diet is the one thing, like I mentioned, that we can control. We can't really control the weather, and sometimes can't control the stress level or things that occur during the day. So that's the reason why we focus on that. There are medications, again, that can be added and supplements if necessary. BPPV is treated easily with home exercises, but can recur and be a frustrating problem. And sudden hearing loss is the one emergency that I really stress be treated and seen by an ear, nose, and throat specialist, because it's something that we really need to treat quickly if we want to get that hearing back. So we have clinics in Midland and Petoskey, and happy to see anyone in the future for any issues. Thank you very much.
Thank you, Dr. Colby. That was such great information. And we do have a number of questions that were submitted from our viewers. So we will get to the first one from Elena. And if someone is experiencing sudden vertigo, are there any tips to help alleviate the symptoms until you can get a more comfortable or safe place?
Great question. So some things that can be done to essentially decrease the balance input or the vestibular system, we want to put it to sleep so that it stops causing the dizziness. And so some ways we do that is with antihistamines such as meclizine or dramamine, or those over-the-counter motion sickness medications, which can be helpful. Benadryl can be helpful as well during those immediate attacks, or if you have any anti-nausea medicine at home too.
Okay, great. And our next question we have is from Joseph. Are there any movements you can do at home to correct BPPV?
Yeah, so there's that Epley maneuver, like I mentioned. It's great that you can YouTube it and actually have someone walk you through. Sometimes it's hard, though, if you don't know which ear it may be coming from, because they are side specific. So there are also additional exercises that you can look at called Brandt Daroff exercises, Daroff, that you can look at, that essentially is turning your head and then laying down to one side, turning your head and laying down to another. And there's certain maneuvers like that where if you don't know exactly which side it's coming from and you haven't been evaluated yet, that's a good place to start as well. So Googling or YouTubing BPPV exercises can give you a number of different ones.
Okay, great advice. The next one we have is from Phil. Hey, Candice. Myself, my brothers, father, and his siblings are all extremely prone to motion sickness vertigo. Everything from an elevator ride to stepping on an uneven floor can set us off into extreme nausea, vomiting, dizziness, etc. And when that happens, the only relief is sleeping until the next day. I jumped in late to your presentation and we'll go back and watch the rest. But any ideas what could be causing this? We depend on Dramamine, those electric bracelets, and trying to take, and we don't have the rest of that question, but that should be
it. So motion sickness can be a common problem that's associated with migraine. So actually, sometimes when we treat migraine, we can get that motion sickness and that sensitivity under better control. Dramamine and those things are very helpful as well, like you mentioned. But there are also some inner ear disorders that can cause dizziness that you may want to be evaluated for as well, particularly when you talk about elevators or pressure changes that can cause dizziness. So sometimes we can even put an ear tube in or other things like that if that's present. So that may be worthwhile to be evaluated for. And certainly if you have headache or any other associated symptoms, I would say talking about, avoidance of triggers and considering chronic migraine as a cause too.
Okay. I have a family member who also tries to sleep off their migraine headache. And so that's some good advice.
Yes.
And I know
I have ears on this ear doctor too. So I understand the sickness. So
Thank you. So next from Joseph, does a Dramamine type of medication slow down the healing of vertigo?
That's a great question. So when I mentioned that these antihistamine and sometimes benzodiazepines like Valium or Ativan can be used during a dizzy attack as well, those are meant to really quiet down the vestibular system so that it stops giving that information to cause your brain to be on high alert and cause dizziness. And so we really want to only use those within the first 3 days of having dizziness. You don't want to use them any longer than that. And the reason is because you want the other ear or the other portions of the brain that are not affected to pick up the slack and compensate. And if you put the whole system to sleep, it's not able to do that. So if you chronically take those medications or take them longer for a few days, it can actually leave you feeling dizzy longer. So if you look at dizziness is a common side effect with any medication, but certainly with meclizine or Dramamine, it's actually listed as one of the common side effects is dizziness. And so that's because it can cause dizziness when taken long term.
Okay, I bet a lot of people didn't realize that. And our next question is from Jamie, another long one. I've been experiencing episodes of a sensation that feels like being forced, pushed, pulled a specific direction against my will. One intense, severe episode additionally made me feel forced down against into the ground over and over and stuck there like strong magnets. I have chronic migraine, and a recent MRI looking at the inner ear was normal. My headache specialist and physical therapist are at a loss. Is this considered vertigo? Is this something an ENT would be good to consult?
I think it's always helpful to have another set of eyes when you've been dealing with something for a long time. And so having a conversation with an ENT could be helpful. I wouldn't say that that's true vertigo because vertigo itself is really just defined as a sensation of spinning. So when people get diagnosed with vertigo, it's actually not a diagnosis. I try to equate it like it's saying knee pain. Well, what's the knee pain from? Knee pain's not a diagnosis. So we have to figure out what it's caused from. So vertigo is more of this, just the diagnosis of, or just a sign of spinning. So being pulled to the ground is actually called a drop attack or more consistent with that. And so there are other things that cause those, and it can be chronic migraine, but certainly maybe some further balance testing of the inner ear and additional testing could be helpful to kind of tease that out.
Okay, we have one more question for you, and this comes from Charlene. How can you reduce, and I've heard it pronounced tinnitus, and you pronounced it a different way, caused by vertigo? How do you pronounce that?
I say tinnitus. You can say
Okay.
tinnitus, but
Okay.
tinnitus is typically, yes. So how can you reduce tinnitus? That's a loaded question and a talk in and amongst itself. So tinnitus is essentially a noise that you hear that no one else hears. It's made from the brain, typically in a response to something. So 30 million people have tinnitus. Most of the time, it's due to a hearing loss, and then the brain makes up a noise to compensate for that. But sometimes it can be due to other reasons why the brain would maybe putting you on high alert. If you haven't had a lot of sleep, if you are stressed, if you have migraine. And I often explain too that if any one of us is put in a quiet room for long enough, we will develop tinnitus. It's like if you were in a dark room for long enough, you may see hallucinations because your brain is used to having sound signal coming in. And so that's one of the reasons why you can develop tinnitus. So it depends on what it's from. And that can help determine how we treat it. So most often, if it's from hearing loss, the number one way to treat it is by getting hearing aids and putting sound back in the ear. And that typically dampens it down a bit. Or we have to get the migraine or the vertigo under control, because if we don't get those symptoms under control, then the tinnitus won't improve. Because again, it's more of a reactionary symptom that the brain is trying to tell you that there's something going on.
Okay, that's very interesting. So we can't thank you enough for sharing your time and knowledge with us today, Dr. Colby. For more information about our upcoming programs and health screenings, you can log on to www.mclaren.org/Bay Region and check out the upcoming events. Thanks again for watching, and you have a great day. Bye.